Rally your NICU friends and join NAN at a discount. No matter what institution you're a part of, NAN provides discounts to those who join together. Groups of 3 to 9 save $10 on each registration, and groups of 10 plus save $20 each. The more friends you gather, the more you save. Take advantage of this discount today at nan.org/join. Please note that all members must be a new NAN member to qualify. Hello, and welcome to NANcast. I'm Jill, your host. NAN's journal, Advances in Neonatal Care, is highlighting neonatal pain and stress in an upcoming special series. Thanks to our special guest editors, Dr. Katherine Dudding and Dr. Marliese Nist, they explore a topic that touches the very core of NICU nursing and medicine, neonatal pain and stress. These tiny patients can't speak for themselves, yet the experience of pain and stress has profound effects on their development, recovery, and long-term outcomes. How can we, as NICU nurses and APRNs, better understand, assess, and manage neonatal pain and stress? Joining us today are the guest editors of the series, Dr. Katherine Dudding, a nurse scientist whose research focuses on increasing our understanding of neonates with pain. In particular, she studies neonate-to-nurse communication of pain for quicker pain relief to improve outcomes for neonates using a technology-based intervention. Dr. Marliese Nist is a nurse scientist whose research is focused on neonatal stress and the effects of NICU stress on neurodevelopmental outcomes of preterm infants with an emphasis on nursing interventions to decrease stress or buffer its effects. Together, they will share their insights on how neonatal pain and stress impact both short and long-term outcomes for infants. We'll also explore practical interventions and strategies that nurses can implement to minimize pain and stress, ensuring the best possible care for these vulnerable patients. Let's get right into it. Thank you, ladies, for joining us today. Can you tell us both what inspired you to focus your research on neonatal pain and stress in the NICU?
Sure. Thanks so much for having us today. I'm excited to talk about this area of our work. I am specifically focused on stress as a general concept, and the reason for that is twofold. First, being in the NICU and seeing the distress that infants, particularly preterm infants, experience was really disappointing to me because we have no good interventions to manage stress and we have no good tools to measure it. So that was part of the reason. The other part of the reason was in the first semester of my PhD program, I was reading about the effects of early life toxic stress. And there isn't a whole lot of this done in neonates specifically, but there's a lot in early childhood. And the theories I was coming across really integrated my love of biology. I have a degree in biology as well, and my interest in helping these babies. So that was a perfect marriage of my interests and my passions and my desire to make care better for these babies.
So my interest in the pain aspect for neonates really stemmed from my experience as a bedside nurse. It just got to the point where we're seeing these chronic babies not compatible with life, yet they were in the NICU. We had all these technologies, and yet I didn't think the technologies were good enough to help these babies. And not only the technologies, but the current interventions and care practices that we experience every day, they weren't ever good enough to help these babies who were in pain and to let these parents know that these babies are in pain. And it was one particular baby that I took care of where baby was a trisomy 18 and not compatible with life. And you could literally see this baby suffering, and it was a very complicated situation, teenage parents, but that just really struck a chord with me where I felt, if not me, who can help these babies and, promote the science further and new evidence-based practices for these babies to help relieve their pain in a better way. And just like Marliese said, we don't have any really good tools that can minimize stress or minimize the pain. We have interventions that we can do that can somewhat do that, but it doesn't completely alleviate it. And I think, we as nurses, if we don't do it, who will? And we are there at the bedside 24/7. So that really inspired me to want to tackle this. It's a challenge lifelong throughout my career and in Marliese's career, that we'll be working on this forever. And we still might not come up with the solutions, but maybe just we'll have a small piece in a resolution to helping these babies.
I think one of the things that both Kathy and I are saying too is that there's a real human interest in caring for these babies outside of the technology and the tasks that nurses do at the bedside. And that human nature, unfortunately, in an intensive care environment gets lost. And it's so important. It is so important. They are babies before they're patients. And they are part of a family before anything else. So I think that there is a science behind what we do, clearly, but it's very human and it's very important. And we don't want that to get lost in the tasks and the technology that goes on in the NICU.
No, you're absolutely right. I agree with you, Marliese. And the neonatal intensive care unit, they're born prematurely. Everything's immature, as we know, especially that neurological system. And we are a unit of firsts. That first touch, that first bath, that first heel stick. If we don't make those experiences somewhat, or the least a bit uncomfortable, we are wiring those brains in a way that they shouldn't be wired. And we're changing that wiring. And we do a lot of things right, I think, in the NICU, but I think we have a long way to go and to really optimizing the care for these babies and outcomes.
Well, we are very lucky to have both of you leading the way in this research and making a change. We all know that this is such a vulnerable time in the development of these babies. So anything that we can do as bedside nurses, providers, even parents to help these babies is invaluable for them. And I think to add another layer of difficulty in what your research is doing, oftentimes I think people feel that pain and stress are synonymous, and the babies kind of have the same signals, whether they're pain or stress. We see that even in our pain scores. A lot of them are stress signs, not necessarily pain signs. So can you differentiate that for us?
Sure. So I study stress more broadly, and I think stress gets a bad rap as something that we should always avoid at all costs. And that's not necessarily true. There is a need for some stress and some stress response, or we would not get out of bed in the morning. We have to have that cortisol spike to get us out of bed. So not all stress is bad stress. The babies that scare me the most are the ones where I'm at the bedside, I'm doing a physiologic measure of their stress response. They have something invasive or painful done to them, and then there's no physiologic response. That's sad. That's terrifying. To start out, let's just say that all stress is not bad. However, toxic stress, so that would be the stress that is unrelenting, overwhelming, frequent, for which babies don't have the developmental capacity to manage, that is bad stress. And that's the kind of stress that can change the wiring of their brain, gets embedded into their biology, and changes the way they function forever. So that's bad stress. And it's a really fine line. I don't know what that threshold is for good stress, or sometimes it's called eustress versus distress. I'll talk about this within the context of more toxic stress, so stress that we want to alleviate. Stress is a really challenging concept to measure and to even define. We have lots of terms for it, but it is broadly defined as a response. So there is a stress exposure, something that you experience that causes a stress response. And the stress response is a physiologic response in the body, and it's very non-specific. You would have the same stress response to seeing a snake coming after you as you would having a painful procedure. The stress response doesn't differentiate. The intensity of the response can be different, but you're exposed to a stressor, have a stress response, and then there's an outcome. So it's very broad. Stressors would be anything that would cause that stress response. And I'll let Kathy talk about pain specifically, but pain can certainly cause stress, but not every stressor is painful.
No, thank you, Marliese. And I actually, philosophically, I absolutely agree with you. There is a lot of stress out there, not necessarily painful, but it does get to that threshold. And man, if we could get to that threshold, both of us would be, Nobel Prize laureates right now. So
let's work on that, Kathy.
Yeah, okay, we gotcha. But when we get to that threshold, it is, and you're calling it toxic stress, I call it pain, and that's A-okay. But I always come back to that International Association for Study of Pain, which they just updated in 2020, that a person who reports a pain is a validated experience. And then they had a little caveat after that where they said their inability to communicate, does that mean that person is not experiencing that pain, which that's what our babies do. And how do they do that? They do it through stress signals, just like Marliese so eloquently stated, through our physiological measures, through our behavioral characteristics. So that's what I consider pain to be. And obviously, if we're doing anything invasive, that is painful. That is stress getting to that threshold where it now has crossed over into a pain experience.
In the NICU, we are caring for babies of all gestational ages. How does the stress response and the pain response differ amongst a premature baby and post-term baby that we're caring for in the unit? And how does that progress? Is there a preemie born at 24 weeks and now they're 4 months old in our NICU? What are the changes that we're going to see at the bedside?
So that's a really interesting question as it relates to stress because we don't know. Clearly, the more immature the brain, the more aberrant wiring can occur. For example, an infant at 24 weeks may experience a diaper change as very, very stressful, whereas a 34-weeker probably wouldn't. And part of that is just their developmental capacity. However, interestingly, term infants have a higher stress response, so their cortisol spikes higher than in a preterm infant, and we don't know why that is. Some of that could be how they're perceiving the stressor. I suspect a lot of that is just the developmental nature of those stress response systems and has nothing to do with their perception at all. Their only way really to know what the baby is experiencing would be to do something like a functional MRI or brain scan where we could see what their perception is and what parts of the brain are lighting up and the intensity of that, but we can't reasonably do that. So the answer is we don't know. Things that would be stressful to us, we could assume would be stressful to an infant. But their stress perceptions over time will change based on their genetics and their genetic proclivity for anxiety and the stress response systems and how those function. Their previous experiences, if they've experienced many, many heel sticks over time, they can either become overreactive to heel sticks or the scary one, underreactive to heel sticks. And stress and pain too are protective. We need to know when we're feeling stressed or when we're experiencing pain because we then evolutionarily remove ourselves from that situation. And when they don't have that, that's really scary. So part of my work is trying to understand how do stress responses change based on the gestational age at birth, and how do they change over time in the same baby? Because a baby born at 28 weeks who is now term age is going to have a very different stress response than a baby born at 40 weeks.
No, and I completely agree with you. Our premature babies, they're not even supposed to be here. So how they are perceiving the outside world, outside the womb, is going to be very different than a baby who can stay at least till 37 weeks in that womb. Their wiring neurologically is going to be completely different. They're going to be term. Systems are going to be more mature than a preterm baby at 30 weeks who takes the next 7 to 8 weeks growing, brain, neurological, all the other systems growing in an artificial womb, such as the isolette and all the developmental aids that we have around the baby. I mean, we know from the research that a 28-weeker can discriminate between touch and pain, which to me, that just blows my mind. I mean, and we also know that a 31-weeker cannot sustain a cry long enough to communicate its pain. So I always come back to theory when I think about pain with ALS. I know it's a very well-known theory within the neonatal realm that it's as our systems mature within the environment, we have more of a capacity to adapt to that environment. And of course, as we mature, that environment and interacting with it is not so stressful. And in that premature age, when the babies cannot adapt to that environment, they become very disorganized. They can't self-console. They can't bring themselves to center. And that's where the healthcare provider, and I use that very loosely, whether it be a nurse practitioner, a physician, a nurse, even a parent or caregiver, as a healthcare team member, can come and see babies having problems with that and can bring them back and help them self-console through positioning aids, skin care, skin to skin, as a first measure of alleviating that high stress or pain response. Like I said, I think we do a lot of good things in the NICU to help alleviate that high stress and pain, such as clustering care, that neuroprotective touch, intentional touching, and then just really approaching our neonatal patients from an individual manner. We all know from our experiences that if we've taken care of a baby over the 3-4 days, that we really can pick up on their cues of stress that eventually lead to that painful experience, and really how to handle and help alleviate that pain in that particular patient. So I think that's real important, and why nurses are so important. We are the eyes and ears and the advocates for our babies.
And I think what Marliese said earlier, the humanistic approach to it. And I think once you have a nurse that is really in tune with their baby, that they're caring for, if they're the primary nurse or, with continuity and even the family, to speak up and say, they really don't like when this happens. Maybe we need to pre-medicate, or I'll have another nurse come in and help with containment during that procedure or whatever. So, like you said, Kathy, nurses are the best advocates for these babies. And we don't want to see them, like, as Marliese mentioned, when you're doing an arterial stick and the baby just kind of pulls the hand away right away because they know what's coming. And it's like, that's really sad, that baby's now understanding that when this happens, I'm going to have a painful procedure coming.
And I think there are clearly long-term implications for this. I have a hypothesis that infants in the NICU experience most interactions as painful, stressful, noxious. Somebody's opening my incubator, they're going to do something to me, and it's not going to feel good, and it's going to make me distressed. And we know that children born preterm have higher rates of psychopathology as they enter their teens, and my hypothesis for this is that every interaction early in their life, or most interactions early in their life, were stressful, painful, noxious, and now they're entering puberty, they're having hormonal surges, and every interaction they perceive is going to be anxiety-provoking, and they have higher anxiety because their brains are expecting everything to be anxiety-provoking, and it becomes embedded into their biology. So the more we can do early in life to alleviate that pain or to offer some buffering, the better they will be long-term.
I completely agree with you, Marliese. Anything that we can do to provide that support that would help minimize that high stress pain event would be most helpful in alleviating some of those long-term consequences that we do see. And it's just very, very, very sad. I mean, on a study that I did, it was actually part of my dissertation, I specifically asked the nurses in an interview, what do you think's going on when you open up the isolette and you touch the baby's foot or hand and they withdraw? And the nurses had some very interesting conclusions as to why. Some of them said it's a reflex. Okay, I could see why they would maybe think that. But we had some very astute nurses where they said, well, they've learned that when we come in there and we touch their foot, that it's going to be something painful. They've already learned that, and it doesn't take long. It may be 1 to 2 days, and they're already learning that when we touch their foot, it's going to be something painful. And how very astute of them and wonderful, those are wonderful nurses that are taking care of those babies. They're very in tune to the care of their neonates. So I thought that was very interesting.
And to that point, some of the work that I did not too long ago was looking at the effects of comforting touch provided during care. And parents can do that, and parents should be doing that if they're available. They should be encouraged and empowered to be involved. But nurses can and should do that as well. I did what's called a crossover study where every baby in the study gets the standard care condition, and in that case the nurse just provided care however the nurse typically provided care. I gave no instruction. And in the other condition, the nurses started the caregiving with 1 minute of containment. All they did was put their bare hands, and that bare-handed touch is so critical, put their bare hands on the baby for a minute, did whatever they needed to do, changed the diaper, did some containment barehanded for 30 seconds, finished up the care, positioned the baby, started the feed, and then did another minute of bare hand containment. And we found that the physiologic stress responses during that care and during these 30 minutes after that care, the stress responses were lower than when the nurses just provided standard care. And part of that is because we're helping the baby, as Kathy talked about earlier, to self-console and to regulate. But we're also mitigating some of that noxious touch so that every touch that nurse gives me is not painful. I also get comforting touch from this nurse. So I think it's a really important thing for nurses to be doing regularly. And I realize I've been there. You got to get that care done, and you can't be in there for 45 minutes. But 2.5 minutes of just doing nothing else but comforting touch is so critical, because that's what the brain is expecting at that stage of development. And when they don't get that, it sets the brain up for not understanding social affective touch.
No, that's so true. We as nurses, and we can all speak to this in our careers, where we had 20 minutes to assess this baby, feed this baby, on to the next baby. And that developmental care, it's just so important. The containment, the boundaries that we have and resources available are so important. And yet it's like our staffing acuity, that's not really incorporated in that. Or if you told, the leaders to be at the hospital, well, we're going to have to change our staffing to nurse ratios because our babies need containment and intentional touch. That's very neuroprotective. I mean, can you imagine that conversation? They would laugh in your face. And yet we are setting these babies up for potential long-term effects related to that unintentional touching and creating that hard wiring that is miswired because of the touch that was not comforting. Right. So there is a problem here. There's definitely, we know babies experience at least 14 painful events every day in the NICU as part of the routine care. It's not like nurses are going around pinching babies. But this is part of their routine care. And you can see how this can really exponentially grow if they're there on an average of 2 weeks. That's a lot of pokes and prodding and potential painful procedures. And so what are we as nurses doing about it?
Right.
We even had where if we had a particular baby that was particularly reactive to touch and stress, if we had time, we would have one nurse do the containing and then the other nurse doing the assessing, which was awesome for that baby, but that's just not realistic. Unfortunate. Very unfortunate.
There needs to be a whole lot of changes, systemic changes, so that nurses can practice the way they know they want to and that they should. I think that we need to be very intentional in everything that we do in the NICU. And while we do heel sticks and IV starts and things that are painful, and they're necessary, babies would not survive if we did not do this. So these things are absolutely necessary. But we need to keep in mind that every single interaction we have with a baby, that baby is learning. And so we need to think about, as we approach every single interaction, what are they going to learn from this interaction? Are they going to learn that I'm scary and that if I'm approaching them, they're going to get hurt? Or are they learning that this could be okay, this might be a good thing. I might enjoy this. So we need to be real intentional in that. And again, that doesn't mean that we can't do the things we have to do. We absolutely do those things. But we need to also add in the comforting touch, the developmental touch, the things that babies need as humans. Again, human babies expect to be touched in a comforting, affective way. So those are just some of the things we have to think about as we're approaching every interaction with the baby at the bedside.
Now with the small baby units and the small baby protocols that are coming out, I think we're starting to realize the importance of neuroprotection. I know a lot of units are trying to implement two-person care when doing care on our micro preemies. So hopefully we'll start seeing, we know the results are going to be there, but hopefully it's more pronounced now and it becomes part of our daily care. And stakeholders can see the importance of having the two-nurse care and the effects that it has on the babies. I know where I work, if you have an intubated baby, it's always two people with the baby at all times to ensure ET tube security. But that has such a profound effect on our babies when we're doing the care because there's more containment. So we're able to see those results as well with that. So
that's awesome.
Hopefully the culture and the environment's going to change so we can, mitigate some of these things that we're seeing now with your research.
Well, and you touched on a really great thing there, Jill, is we're developing policies, and we need to develop policies and procedures for pain. What are we going to do? How are we going to escalate this in a least invasive to invasive type of manner? And who's included in that? Parents, caregivers, nurses, physicians, nurse practitioners, everyone on the team, RTs, everyone has to be involved at that policy inception, and everyone needs to be on the same page. So it's not a question of, okay, this baby has been showing this noxious, high toxic stress for a profound period of time, and we've done the developmental care. We've had mom do skin to skin. Baby is still just out of its skin, uncomfortable. What can we progress this? I mean, there should be a flow to this that, okay, well, based on today's events, maybe this baby needs some Tylenol. And, I've said this before to nurse managers, and they're like, well, if you think all babies are going to be sedated, that's not what we're doing. I'm like, that's not what I'm saying. I'm saying we have to have a policy and procedure and a flow. So there is almost like a standard order of, okay, if this occurs, then we can progress there, or contact your provider so we can get an order for a PRN, something. There's so many units out there that don't have that protocol in place, and then the nurses are too busy. They don't have the time to ask, or they don't want to ask because so-and-so is on and they know what the answer is going to be. And, that's really sad. Ultimately, we need to come back and say, if this was my child, would you hope that the nurse would advocate for my baby? Of course. And I always tried to get into that mindset that, no, this isn't my baby, but this is my baby for 12 hours, as far as the care goes, the advocacy goes, along with the parents. I'm part of this healthcare team in optimizing pain relief measures and discomfort for this baby. So I just think we just need to think a little bit about getting those pain protocols in place, so we can really help these babies and everyone's on the same page. There's no question on what the next step's going to be.
I think, Jill, you hit on a really interesting and important discussion when you said that they implemented two-person cares for intubated babies to make sure that ET tube is secure. And this speaks to nurses and the importance of understanding what matters to the stakeholders. So it's really hard for us at the bedside as researchers, as nurses, to advocate for stress and pain management because that's a difficult thing to measure. And it's a really difficult thing to show long-term outcomes that are directly associated with that. We know they're there, but it's hard. It's a very hard thing to have people outside of the NICU understand. But when you say to them, if this baby extubates, you have an unintentional accidental extubation on your record. Well, they care about that. So now you have two-person cares, you have an outcome or a metric that the stakeholders care about, and oh, by the way, you get an extra nurse to help provide some comfort and pain relief and stress management during that care. So what a great win-win for the baby more than anybody else, but for the baby and the stakeholders are now getting what they want. So it is important, as Kathy was saying, that nurses have some understanding of policy. It doesn't mean you need to go get a degree in public administration. I don't have one. I don't know if Kathy does, but we don't need that. But knowing how to talk to the stakeholders and knowing what's important to them is a really important way that we can advocate for our patients.
So we're talking a lot about the pain response, those toxic stress responses, but as nurses, how do we measure those, or what are the tools that we can use to quantify that so we can go to our providers and say, hey, my baby is in pain. I need X, Y, or Z. So what are those tools that are out there that we could use for measuring and quantifying?
Well, we know from the research that there's over 40 different neonatal pain scales out there. I was blown away when I heard that. I'm like, what? I can't believe that. And it was interesting to me, not one pain scale could be used to measure pain as best as we can in a subjective manner out there. Every pain scale, like NIPS versus MPAS versus FLACS, those pain scales are all very specific for specific pain, whether it be acute pain, prolonged pain, postoperative pain. The list goes on and on. The normal NICU nurse would not ever know this. And then they're also very specific for gestational age, which I did not know. So NIPS is more termish babies, even though what happens oftentimes is that we will have a pain scale that is for, let's say, acute pain. For term babies, what they'll do is the founders and creators of that pain scale will try to get it validated for a lower gestational age. And so they'll do a study with that to get that validated for that lower gestational age. And what's interesting is that part of my dissertation work is that there was no standard that these pain scales were being held to on how we determine the reliability and validity of the tool that they're using. And so what I was seeing in the literature was, well, this pain scale, they're saying that it's validated and reliable. Let me just use my pain scale with theirs, and if we get similar results, then mine's validated too and reliable. And I'm like, well, that's not exactly how you would do that, but okay. So, I mean, we do have issues with the current pain scales. You know, the psychometric properties might be a little bit lacking, but I mean, really, honestly, that is the best tool we have. They're subjective. They're based on nursing experience. The literature even says that nurses who are more novice are going to detect pain better than a nurse who is more experienced, which that's kind of interesting in and of itself. And then we also know that through that subjectivity of our own pain experiences, we might be biased. And so that also plays into how we assess another, let alone a neonate's pain.
Yeah, and stress is an incredibly difficult concept to measure. We have no good measures for stress. When we talk about stress, as I said before, there's stress exposure, there's the stress response, and there's stress perception. So stress exposure is simply what a baby experiences. And there are some things people look at, particularly in research, they'll look at counts of invasive procedures or counts of skin-breaking procedures. There's a measure that was developed in Australia called the Neonatal Infant Stressor Scale, which is essentially a checklist of experiences, and it includes things like diaper changes and gavage feedings and intubations, IV sticks. And these items are weighted for their presumed intensity by experts. Unfortunately, none of these measures consistently associate with physiologic stress responses. So we don't really know, other than maybe bringing an awareness to how many stressors a baby has experienced in a given day. We don't really know how to use these tools. They could be very helpful, as I said, if you have for example, in the neonatal infant stressor scale at the bedside, and you notice this baby's had 6 heel sticks today, that's a lot. Maybe we need to back off on labs or just manage stress in a different way. So it could be helpful in that way, but I can't give you a threshold where that stress becomes toxic or where that stress is now going to affect long-term outcomes. So that's stress exposure. There are measures, they're not really not validated, and we don't really know how to use them. Stress perception can be measured in children and adults by simply asking them, how stressed are you at this time? And there are all kinds of great self-report measures for stress perception. We can't ask these babies. And we try to rely on their behaviors, which are okay because that's what we have at the bedside. We can observe behaviors, but behaviors don't necessarily indicate much. They don't actually correlate with EEG signals during stress exposure. And that can be because of the neuromuscular immaturity of the baby's attempts to reserve energy, all kinds of things. So we have no way to measure stress perception. Stress responses are a little bit easier, although not accessible to the nurse at the bedside. I measure skin conductance responses, which are sympathetic activations, and they will tell you when that sympathetic nervous system becomes activated. There's also things like heart rate variability that tells you when the sympathetic nervous system becomes activated. But these are challenging to use because A, they're not accessible at the bedside, and B, those systems are changing over time. So there's no normal. I can't tell you what a normal sympathetic nervous system response is. And if we had no sympathetic nervous system response, the babies would be bradycardic all the time. And that's not a good thing either. So I think the best thing to do is the primary nursing that we were talking about earlier, where a nurse has a baby consistently. They get to know that baby and that baby's individual cues. And then in that way, the baby does talk to the nurse. So some babies may exhibit more behaviors than others. So being aware of the behavioral cues, those are accessible to us at the bedside. Things like heart rate, respiratory rate, apnea, bradycardia, all of those things are useful, particularly if you know an infant's baseline. But to know a baby's baseline, you have to be with that infant for some period of time. A heart rate of 160 may be fine or it may be terrible. It depends on what the infant's baseline is. So knowing the baby and doing that primary nursing and listening to the parents just have, in addition to being with their infants the most, there is a biological connection there. I am absolutely convinced of it. And they just know their baby. So listening to parents, even though we may be the experts in providing nursing care, those parents just know their baby. So when they say their baby's stressed, I would take that to the bank. Their baby is stressed. But it is very difficult to measure, and we're working on it. I promise. That is one of my research aims, is trying to figure out how do I help nurses identify when a baby is stressed to the point that it's going to affect either short or long-term outcomes. So we're trying. Kathy and I are trying.
Yeah.
It's going to take a lifetime.
Yes, it is. It is. And it is very individualistic. We do have to approach these babies individually, but we can't just rely, just like Marliese was saying, on the behavioral characteristics or the physiological characteristics. This is a multimodal problem, meaning we are seeing it from all different systems. And yes, these babies are communicating to us. Now, a baby at 24 weeks is not going to be able to communicate their pain like a 37-weeker. It's just not going to happen. We don't have the muscle tone. We're all immature at a 30-weeker versus a full-fledged 37-weeker. So we need to be very cognizant of how they're communicating and knowing that baby individually and then going from there.
I think it's interesting about the physiological characteristics because oftentimes I think people look at what are the vital signs to determine if the baby has pain. And that really drives decision making as far as if we're going to intervene medically with, increasing infusions or giving a PRN. And sometimes it's just, what is that number that we have on that pain scale? And sometimes I've seen providers not ask the nurse and just go by that number, or looking at the monitor in that time, in that blimp of time, and see that, they're clinically, they look fine on the monitor. They don't need any more pain medication. So what are your thoughts on that? And as far as a nurse to advocate for their patient if they find themselves in that situation.
Yeah, in that situation, especially if you've been saying all day this baby's physiologically not doing well, behavioral, we're showing signs of that high stress pain response, and then the healthcare provider looks and says, baby's fine. Well, have them go look in the EHR. Look at the trending. Trending is so important. That can tell us almost in real time, through time, over those last couple of hours that you have been seeing this, of what the baby's been doing. Now, I mean, there is a little bit of a lag in those monitors. They're not perfect, but nothing's perfect that we have right now. But it's something. Trending is so important, and it's not just the physiological, it's the behavioral. It's what the parents are saying. You have to take that all into context to tell that story of pain in that baby. And unfortunately, monitors aren't going to do it alone. We really have to be very cognizant, and we as nurses need to be cognizant of how we are telling that story. We need to make sure we're covering all the bases. Do your physical assessment. Look at your behavioral characteristics. Look at your physiological characteristics. Look at what's been going on with that baby during the day. Look at your EHR. Once you have gathered all that information, then go to your healthcare provider and say, in an intelligent manner, say, over the course of this period of my shift, this is what I've been seeing. And I think you might have a better response. No guarantees, but if you come to the table with your knowledge on that baby to deliver to that healthcare provider, I think your results might be a little bit better. What do you think, Marliese, on that topic?
No, I completely agree. And I think this is another situation where it's really important and really helpful when we have primary nursing. I keep going back to that. But a baby may be sitting at a heart rate of 150 all day and we think he's fine. But 2 days ago, he was at 135. So this is also a good place where trending over long periods of time and being cognizant of the stress exposure or the painful procedures over a period of time may be helpful, because the baby's heart rate was 135 on Tuesday. Now it's Thursday and it's 150. But, oh, by the way, we did 10 heel sticks in the last 24 hours. And I have actually seen that in my research. So being aware of that, we're taking into, exactly as Kathy said, many different factors: the stress exposure, the physiological signs, the behavioral characteristics, what the parents are saying, what nurses who know this baby are saying. Nurses have great intuition and a great ability to think critically. And I think integrating that and teaching, when we precept new nurses, precepting them and training them to integrate all of that knowledge and be empowered to speak up is really helpful.
Marliese, with you saying, look back and see what kind of procedures were done on this baby in that time frame is really good evidence to show that this is why this baby is having these kind of responses. Because oftentimes that's not, you can't get that in a number from a scale, a pain scale. And
right.
I think that's extra data to be able to show that this baby needs some kind of intervention or management change in that baby's plan.
And again, that's going back and looking, and maybe I just came on shift at 7 o'clock in the morning, and I don't really know what happened at night procedure-wise. I knew there were heel sticks going on, but maybe not as many. But then you go back and you actually go back and trend that day. Oh my gosh, in this last 12 hours, we've had 10 heel sticks. I mean, yes, that's huge, and that's going to affect your day as a day shift nurse based on what was going on previously. So trending is so important. And again, that does take some extra time to actually look at the data within the EHR. Retrievability can be a little difficult sometimes, finding all that data, but that's so important to tell that story of what's going on with that baby.
And as an intervention point, I know, Kathy, you're really involved in informatics. Our systems are just not set up for nurses to do the best job they possibly can, because they're set up for billing, really. So we can't get the whole story the way so the more involved nurses are in creating these electronic health record systems, the better we're going to be able to care for our infants. And I think the better outcomes we'll see, because the data that we need to do our jobs to the best of our abilities will be available to us.
Yeah, I completely agree with you. We're working on it.
That's way above my ability to think, that whole technology thing. So Good for
Yes.
you.
No, you're absolutely right, and you hit on something that was has been so frustrating for me as when these electronic health records were implemented at the bedside. Either nurses weren't involved or nurses were involved, their opinions were given and no one listened to them. And now we have unintended consequences related to electronic health records. I actually wrote a paper on that. So no, you're absolutely right. And you're right. The EHR is set up for billing metrics, making sure we're hitting the metrics. Is the baby in pain or not? Yes or no. There's no further detail into that. Sometimes we have the pain scales loaded into the EHR, so it's digitized within the EHR, so we can use that, and that can be a part of the metrics, but not always. And then nurses' notes. That's not in a usable manner for the most part on the electronic health record. They want it in very structured, discrete fields. Unfortunately, our clinical notes are unstructured data, and unless that electronic health record is set up for large language modeling of those clinical notes and pulling that data out of there, it's not going to be used.
We tend to focus just on our babies and their journey in the NICU, and all of our efforts are in, helping alleviate pain and stress in the NICU. But what are the long-term effects of pain and stress? Even though we think we're doing our best, after they leave the NICU, what are we seeing in these NICU babies after they leave the NICU and start to grow and develop?
That's a great question. There's more and more research coming out now looking at long-term effects, particularly in preterm infants. And they're seeing that using these sort of crude measures of stress exposure, like invasive procedures or skin breaking procedures or the neonatal infant stressor scale, that the more stressors infants experience in the NICU, the poorer their outcomes are. And these outcomes include particularly things like cognitive development. They have poor educational attainment, academic attainment. They can have delayed motor development. They can have delayed language acquisition. They can also have some profound socio-emotional effects. And these are observed in early childhood. We're just now getting to where we're looking at more long-term effects. But as I mentioned earlier, there's higher rates of psychopathology based on the number of stress experiences infants have in the NICU. So the data are just coming out on this. It's difficult to tease out the effects of stress versus critical illness because they're highly correlated. Obviously, the sicker you are, the more procedures you have done to you. But with some advanced statistical knowledge and some large sample sizes, we are seeing that even when you can control for the illness severity, the long-term effects of stress exposure exist in these infants, and it's striking and it's disappointing, and it's a call to action for both researchers and bedside nurses. A lot of my work is focused on what the mediators are of stress exposure and neurodevelopment. How is the body changed as a result of this stress exposure in the NICU? And we're finding that things like neurological wiring is different, as well as biological functions. The immune system functions differently. The autonomic nervous system functions differently. There are changes to our epigenetics, and that's changes to the DNA structure. So the sequence of your DNA is permanent. It does not change, save a strange mutation. But there are tags put on your DNA that changes how the genes are expressed, and those tags are very responsive to the environment. So our DNA structure changes and our gene expression changes as a result of what we experience. And these can be not just permanent, but they can be heritable. So I have often thought, as I'm looking at a little baby in the NICU, your grandchildren are going to be affected by what you are experiencing as a 24-weeker in the NICU. And that has profound consequences. So there are long-term consequences. We're starting to learn more and more, and that's something that we're working on, not just figuring out how it gets embedded into our biology, but what we do to interrupt that pathway.
No, and you make a great point, Marliese. This is something that's going to affect the lifetime of this baby. And it's not something, and I'm not minimizing any kind of chronic illness that occurs as we age, hypertension, cancer, whatever. But this is something from day one, baby is slowly being affected by, and it is intergenerational. And we can even go back to the flip side. If we look at the mom, if mom had social determinants of health, had poor prenatal care, had food insecurity, house insecurity, that in itself is stressful on that mom and when baby is in utero. And that is going to change the DNA of the baby at that point in time too. So you can see through the generations how this can really affect the life of a child.
Knowing this negative impact on the developing brain and the long-term outcomes and how profound they are, what can we do as NICU nurses, providers, even parents to help intervene and decrease this pain and stress that these NICU babies are experiencing?
I think that's really important. The primary thing that I think about is, as I said earlier, to be intentional in every interaction we have. If there's an opportunity to provide some sort of comfort for a stressful experience, then we need to do it. That may be involving the parents, that may be getting a second provider, that may be just taking an extra 30 seconds in whatever we're doing to provide some exclusive comforting touch and to treat them like human babies before anything else. They have the same needs as any other human baby, and that is to be comforted, to have affective social touch, and to have their developmental needs supported in the NICU. So that's number one, is just being very intentional in every interaction that we have with them. Learning our babies and taking the time to learn them so that we know what their baseline is and we can learn those very subtle individual cues, and not assuming that because there are no behavioral responses, the baby is fine. That is right. Almost never the case. Behaviors can be great at telling us when there's a problem. They're not great at telling us when there's not a problem. So the absence of behaviors does not mean the absence of a problem. But knowing that baby is really important. Involving parents, as we've said, some of my work right now is actually looking at the buffering effect of parents in the NICU and how they may better support their child's development and management of stress. And that comes from early childhood literature as well, that infants or young children who experience toxic stress early in life, who have nurturing parents, do much better than children who experience the same things and don't have that nurturing support. So that nurturing presence is biologically, evolutionarily required and important for the infants. Sir, I'll let Kathy talk specifically about pain, but as far as stress, just being very aware, taking some pauses, pacing our cares, keeping track of what the infant has experienced. I don't know that clustered care is necessarily the right way to provide care if your clustered care is going to involve 10 different procedures. That may be absolutely overwhelming, and maybe we just need to be very intentional about how we're going to provide care and how we're going to pace care throughout the day. Not everything needs to be done at that moment, and not everything even needs to be done all the time. If we can let babies sleep and rest, and we don't have to get in there absolutely every 3 hours on the nose to do these things, and that's where nurses need to advocate as for policy and procedures. You know, our policies require us to reposition the babies every 3 hours. You would not go in and reposition your healthy baby every 3 hours if they're sleeping. So being aware of when the baby's uncomfortable and maybe does need to be repositioned, but treating them as human babies before anything else, I think, is critical.
No, Marliese, I love, and as Jill had said too, that humanistic, use your common sense. Would this be something you would do with your baby? We've had many babies where they were admitted and, oh, wait, it's time to assess them again, and it's only been an hour. Well, you can give them an extra hour. We are growing brains here, and we need to give them the time to recover from all of this stress. But, I do align quite a bit with the American Academy of Pediatrics in their statement that was given out in 2017. Pain policies and procedures, that is so important. I'm alarmed on how many NICUs don't have a policy and procedure when it comes to this. And you might even have to have a policy and procedure for different gestational weeks, because we know babies change every week, every time they grow. Every week we're going to be looking at babies for that high stress pain response in a much different way than we did the week before. Be cognizant, be the champion on your unit, that maybe you have someone who's like, okay, well, I'll look up these pain scales that we're using and to see if they're appropriate for the unit and the pain that we're measuring here. Like a children's hospital, we're going to be looking at a lot of post-operative type pain. Well, then that's the kind of pain scale we should be using. So be cognizant of that. We as nurses need to educate ourselves, and it's not just educate ourselves on what the hospital is providing us. We need to be reading our professional journals. So important. We are lifetime learners. I know we don't like to hear that, but we really are. Things are changing so fast. We need to be going to conferences, learning. There's always a pearl of wisdom that you can learn, I promise you, at a conference that you did not know before that you could bring back to your unit. Developmental care, we know that purposeful touch, and just being very inclusive of including our parents and our caregivers in the why on what we're doing. Why are we containing our babies? That's a great way to get them involved with it. I mean, we all know that parents can't be there 24/7. In fact, it's very rare these days that we have parents that can be there. But when they can be there, oh, what an amazing gift that is, not only you as a nurse to have those second pair of hands for containment purposes during a painful procedure, providing skin to skin before, after, during that painful procedure. I mean, just parents are really important in our NICU, and I know oftentimes they feel like they're not doing anything to help their baby and they want to be a part of it. And maybe we as nurses aren't doing a good job to say, oh, by you doing X, Y, and Z, you are providing an enormous comfort and pain relief to our babies that we can't do ourselves. So I think that's really important, that we always give them the why behind things and tell them what the benefits are to the interventions they are doing. Facilitated tuck is another great one. If they can't be there, hey, we have something that smells like mom, and we can put that in that bed during that painful procedure. We just really need to continue our education. And then also, as research nurses, we need to continue our efforts with these studies. And hey, maybe Marliese, and maybe in our time period, in our careers, we will be able to get to know what that threshold is and what an amazing gift that would be for our babies, and to optimize and hopefully minimize and maybe potentially alleviate those long-term outcomes in these babies.
Yeah, I really want to empower nurses to be fearless, get involved,
Yep.
speak up
Absolutely.
for your patients. Nurses are smart, knowledgeable, educated scientists at the bedside, and they have such great power that I don't think we often use or that we tap into. So get involved in the policy making bodies in your units, get involved in the hospital letter, get involved as much as you can, speak up, be fearless. I think nurses are the absolute best advocates for the infants because they're there at the bedside all the time.
Absolutely.
And for the parents as well. Parents are great advocates for their own babies, and we can do the same.
Adding additionally to what you just said, we need to empower ourselves, but also empower our parents and our caregivers that are there providing care. Just like you said, they know the babies. We know the babies after we've cared for them over several days, but they know their babies. We have an important role to play, and it's beyond just caring for the babies. It's advocacy and empowering our parents.
And I would love to see a lot of collaboration between research and clinical practice. I can't practice clinically anymore. I don't have the time. But I need to know, what do you need at the bedside? What can I do? How can we work together because we're all interested in improving the experiences and the outcomes of these infants. What do you need? What do you need research on? Talk to us. Because there's sometimes that I feel a little disconnected, even though I practiced for a very long time, and I still go to the clinical conferences to try to keep a toe in it and know what's happening. we have to all communicate because we're all working for the same goal ultimately.
Absolutely. And it just like you said, we're all at different levels, whether nurse practitioners or we're bedside nurses or we're researchers or we're policies. We as nurses need to all come together because we all do have that same goal and want really good outcomes for our babies.
Thank you both for joining us today. I think that you have really provided nurses with so much knowledge that they can bring to their unit and be those fearless leaders and advocates that you mentioned, and really try to strive and bring change and be intentional in all of their interactions, tell the journey of the pain story. I loved that aspect because it's more than just a number. It's more than just the physiological characteristics we are seeing. So everybody be on the lookout for the special series on pain and stress that's coming out in January and February. So thank you guys for joining us today. Make sure you never miss an episode of NANcast by subscribing now. This podcast is made possible by listeners like you. Thanks for your support and letting us into your ears. Have a great day.